Our next speaker is Dr. Doug Nunemaker, who I had the privilege of having lunch with. They have a $1.75 chicken fried steak downstairs in honor of the Skirvin's 100th anniversary. Dr. Nunemaker is board certified in family medicine. He practices in Wichita. He also holds an associate faculty position with the KU School of Medicine in Wichita. He's with Atlas MD, where he's been able to cut ties with insurance companies and provide medical care as he was trained to. And as he's making his way up, I'll note for those of you who are savvy on social media or are live tweeting, there are some people live tweeting various parts of the event. The handles are at Free Market Care and at the Kempton Group. People are putting photos up as well, and the hashtag is FMMA, Free Market Medical Association. So just hashtag FMMA, and Dr. Nunemaker, please take the stage. Thank you.
Hello. As you can see, I'm not Dr. Umber. He had some campaigning issues to do today. He's running for lieutenant governor in Kansas, so couldn't be in two places at once. So I'm filling in for him. I'm one of the founders of Atlas MD, which is a direct primary care practice in Wichita. I'll start with a little bit of a background of what Atlas does, why we do it. I'll talk some about what we've been able to accomplish with insurers, employers, transitioning physicians, even building a de novo standalone EMR for use with direct primary care. So Atlas MD, we realized in primary care, am I too loud? Okay. Insurance complicates more things than it helps, especially in primary care. And to make that easier to understand, let's look at trying to insure something else that's otherwise inexpensive. So let's use car insurance to insure gasoline. Gasoline's not expensive. It's more expensive than it was, but it's not expensive, certainly not expensive enough to insure. But if we did, one, there would be no marquee out on the sidewalk at the street corner. You'd have no idea how much gas costs. You pull up to the pump. Again, there's no indicator. You have no idea what you're paying. Person at the pump next to you is going to get a different price because they have a different plan. They might be at an out-of-network pump station, so even worse. The insurance company would tell you where you could get gas, what grade of fuel you could get. You would have to pre-authorize trips out of town and vacations. So you can see how it kind of is starting to get out of control. People wouldn't do that. But that's exactly what we're trying to do in healthcare. It's what we've done for decades. We insure something like primary care that's not really expensive when you get down to it, but we're trying to insure it anyway. So get rid of insurance. You're left with one of two options. Either charge people as they come in. It's still a fee-for-service model, kind of a rat race. You know, you have to keep your office full. If you don't have people in there, not going to generate revenue. Or you can do what we've done, which is a membership-style model. So you pay a monthly fee, just like AAA, or a gym membership. You can use it as much as you'd like because that's really what primary care is all about. It's access to your provider for various questions. Josh even got a question from a patient asking him where a shoe store was that he had referred him to, but they have our cell phone number, so he called and asked. You can come into the office as much as you'd like. You can call, text, email. Josh diagnosed a UTI on Twitter. So you can utilize technology for what it's worth if patients are willing to tweet their symptoms. And make the pricing simple. Just like Steve Jobs said, Leonardo da Vinci said, simplicity is the ultimate sophistication. So $10 for kids, $50 for most adults for unlimited care. And that's it. Anything we can do in the office is included. Stitches, free. If you need an EKG, also free. We have a DEXA. We can do a urinalysis, strep throat testing. We have a spirometry, ultrasound, skin biopsies, lesion removals, joint injections. All of these things they're not expensive for me to do in the office. Again, stitches maybe cost me $1, but I can absorb that as the cost of doing business. So you don't need to insure it, and I don't really want to have to worry about trying to bill for it. We also realized that we needed to make other aspects of medicine affordable. So looking at medications and labs. By the way, just like Dr. Rice, I'm more than happy if you guys want to stop me and ask questions so you don't forget them. Please do. It's a very open forum. But looking at medications, for example, Walmart changed the industry when they went with the $4 list. The other supermarkets, other facilities had to either adapt, do the same, or if you're somebody like Walgreens, they operate 24-hour clinics, or 24-hour pharmacies, so they haven't changed. But supermarkets, if they didn't change to the $4 list, they were going to lose out. So we saw prices steadily creeping up for a lot of medicines that now they're just standard at $4. Well, I can tell you a lot of those medicines are 1 or 2 cents a pill because I dispense them. And all but about 6 states in the U.S. allow you to dispense medicines. So I order them in wholesale, I inventory them in my office, and I dispense them to the patient at cost. So I've had patients, was it Josh? He dispensed somewhere close to 1,000 pills for a patient between metformin, some blood pressure pills, and various other things, gabapentin, and it came out to somewhere around $85 for almost 1,000 pills of various different medicines. That quite easily saved the patient more than their membership cost. So in this instant, just the patient using our clinic as a dispensary is saving money. Plus they leave the clinic with medicine, so I know if I give them 30 days of medicine and they don't call me in 30 days, they're not taking for a refill, they're not taking their medicine. So that saves them money, and it's considerably convenient. Now, if they're on the other side of town, I also know what medicines cost. We use GoodRx quite a bit, goodrx.com. So I can look to see how much a medicine is going to cost, and it shows very clearly Walgreens, Walmart, Dillon's, wherever. It gives me the price, either cash or with a coupon, which you can print or text or email to the patient for free. So Josh, he had a patient, she was going to fill a fluconazole, some diflucan. Went to the pharmacy and it was over $200, and she was mad because Josh told her it would be like $12. And he said, well, did you give him the coupon? She said, well, no, I thought you sent that with the prescription. He said, oh no, I apologize. You have to show them the coupon. Went back in, $12. So just because she now had this coupon, it went from $200 to $12. You know, pharmacist doesn't think anything of it. It's just the way it is, but patients don't know that. We can do the same thing with labs. Go to an ER or a hospital, charged several $100s for, let's say, a comprehensive metabolic panel looking at liver, kidney function, things like that. We do it for $4. A blood count is $2. Cholesterol is $3. But that's discounted price straight to the patient. So there's no incentive. I make no money on it. If I say, I think we should check your thyroid, it's because I really think we should check your thyroid. I'm not going to make $10 doing it. It's $4. You pay the $4. If you say, you know, I don't think it's worth it, well, that's fine. We've had the discussion. I clearly think you need it, but it's your $4. So you enter into that discussion like anybody else. If you want to have it checked every month, I still don't care. It's your $4. Probably not necessary, but we can do that. Imaging, same thing. Just like any other business, you make other businesses compete for your money. So we went to the imaging facilities in Wichita, and one in particular said, we will not be undercut. And sure enough, they weren't the lowest in some, we told them that, and they lowered the price. The equipment is the same. They still have good MRIs, good CT scanners. The quality is there. We like their customer service. But I know I can get a CT of somebody's head, of their brain, for $175 every day. And I can tell the patient that. If they say, you know, I tell them, you know, we've worked up your headaches. I'm really concerned about something. I think we should get a CT. It's going to cost this. If it's in their budget, great. If it's not, you know, we'll talk about it. But again, they get to make that decision with their dollars. If they have insurance, those facilities still bill insurance. So if their copay is less than $175, use your insurance. But I can tell you, if you've got a copay that's that low, your insurance company's paying a lot, and it's probably going to hit your premium or your employer's bottom line sooner or later. So those are the things that you can do when you look at just the free market. Again, I'm no different than a mechanic. Car's broken, mechanic fixes it, pay the mechanic. And you know what the parts are going to cost when you go, and how much labor it's going to take, and how much their hourly rate is. Again, if you went to a mechanic and they didn't have their prices up there, so well, what's your hourly rate? What's your insurance? You wouldn't do that. You'd go to somebody that's just going to tell you how much they cost. So that's the biggest difference with how we operate versus a standalone insurance operating clinic. And we've been doing it for over 4 years now. It was September 2nd of 2010 that we opened up Atlas in Wichita, and have been very successful. So much so that we've gotten some physicians around the country doing the same thing. And that's one of the reasons that we wanted to speak here is how do you promote this? How do you get other doctors? We're a risk-adverse group. How do you get them to understand the disparities? And actually, Dr. Rice used the example of surgery for his son. And not to beat a dead horse, but I find they're the most easily beaten. My second son, don't have maternity coverage because it was too expensive for the clinic. But my second son was born one day in the hospital, no complications. Bill from, and this isn't the OB or anesthesia, this is just the hospital, $17,440. Again, no insurance, so I told him, well, I'm going to be paying this cash. What is it? $1,915. And just because it's cash, now they can close the books on it. But an 89% discount, just, and I actually mentioned that when I was up on Capitol Hill in Topeka, and some of the people that are supposed to be making our laws, they were blown away. Said, well, we need to investigate. That is wrong. I said, wow, this has been going on for decades, guys. This isn't new. And I grew up with the background of medicine, the business of medicine. My dad was actually a hospital CEO for about 40 years until he retired, just actually for his last 12 or 13 years in Chickasha. Don't hold that against me, though. He was very physician-friendly. He got the Friend of Medicine Award by the Oklahoma Medical Association. So he understands exactly what we're trying to do and was very friendly towards that, although I understand, speaking to someone earlier, that the OMA isn't, or the Oklahoma Hospital Association isn't necessarily a friend of medicine, unfortunately. But let's get into talking about employers. What can we do for employers? And third-party administrators, actually, we work great with. I talked to the CEO of one up in Kansas City, and he just could not understand how if I charged patients, or if his company was charging less for premiums, how he was possibly going to make more money, because that's what I told him. When he asked, well, how can I benefit working with you? I said, well, I'm going to make you a lot of money. He liked that, but didn't understand how lowering premiums could do that. So, well, let's look at it this way. If you raise premiums, the people who are going to look at whether their insurance is worth it or not are the people who aren't using it. And they say, this increase, I'm really not using my insurance, I'm just going to cancel it. So you just lost the people that you weren't paying anything for, paying out anything, and they were a good revenue source. So you lost them. People who use it all the time, they're going to stick with you until they absolutely can't anymore because they're getting the most value. Sometimes they're getting more out of it than they're paying you. So you've lost in that direction. Well, make it more affordable, decrease premiums, and sell it to more people. If you lower your premiums, how are you going to make it work? Well, utilize direct primary care. I don't bill insurance for anything. So with an ERISA or a self-funded plan, the insurer, the company, has a risk pool. And every time somebody has cough, cold, sniffles, anything, go to the doctor, and every time they bill insurance, and a little bit comes out of that risk pool. Well, the company doesn't want that, because the more of that left over at the end of the year, they can reinvest that into next year's premiums. Well, I don't bill any of that. The patients already pay me my fee, and actually, a lot of times companies do that because a company can payroll deduct my fee from, for the employee, and they actually avoid the payroll tax on that, so it's a benefit to the employer. But if you aren't paying out for all of the nickel and dime stuff, sometimes 40 to 50% of what's paid out for an insurer is primary care. Granted, primary care isn't an expensive bit, but it's all the administrative work that comes with the volume of claims. A patient might only have one hip surgery, but they've seen their primary doc 30 times now. So all of that administration is now cut out. You still have the hip surgery. We still need insurance. I have car insurance, I have homeowners insurance, life insurance, but I don't expect to use those except, in a catastrophe. So that's what health insurance really needs to be turned back into. And that's what we talk to insurers about. Let's take primary care out of the loop. You don't need to insure it. Again, it's like insuring gasoline. I can take care of labs, meds, imaging, things like that, and all of the primary care. We don't need to insure that. So it works exceptionally well with these plans. Several examples. Johnson's Garden Center. It was a company, fourth generation gardening, lawn and garden company in Wichita. Sat down with all their employees and said, we've cinched up our belt as much as we can. We've cut corners. We're right at the limit. Our premium's going up 20% again. We can't absorb that. So we either need to let some people go or we just can't offer insurance anymore, neither of which was palatable. Well, that's right when we started up, so we said, well, maybe we can work with you, change up your plan. So we did. We worked with an insurer to customize an ERISA-style plan. We cut out all of the primary care, so office visits, all of that, that's not covered now because it doesn't need to be. Their insurance premiums went down from what it was, and it was going to go up 20%. From their current, it went down 50%. So Johnson said, well, we like this so much, we want people to participate. We'll pay half of your monthly fee in order to have our employees see you as their physician. So after they did that, it cut in, they saved about 40% at that point. But again, a 60% swing from what they were going to pay. And we've done that every year now. We went an entire year, and for those of you that understand how insurance works, every time you file a claim, your insurance, your premium kind of takes a hit. You get an experience rating. We don't report to the insurance companies, so you don't have an experience rating. So your geographic region, they get a certain percent increase regardless. Everyone does. But there's nothing more than that. So we looked at Johnson's rates, and they went up by just that experience rating. So our insurer came back and was asking us about that and said, did they ever see you? Oh yeah, no, we did after hours care, stitches, all kinds of routine care, a lot of stuff. Why? Like, well, their rates didn't go up. And then you could finally start to see that it was clicking, that, well, there was no experience rating. They filed 0 claims. And actually just until their third year, Johnson's Garden Center employees, which is about 50, filed no claims for 3 years. And they were getting care. That's the thing. It's not like we cut their insurance and said, if you go to a doctor, the Gestapo is going to come after you. No. They were getting care. But we just weren't billing insurance. So why not do that? Why not save employers money, make insurers more money? We like insurers, some. We want them to be around. We want there to be more options. We want them to compete. In order to do that, I need to make them profitable. If they go under, we're going to have a single payer system, which we absolutely don't want. We need to improve the health of patients and save them money. We need to improve the satisfaction, the professional satisfaction of physicians. That's what this does. That's what the goal of direct primary care is. And it works with other specialists, physicians, like cardiologists, endocrinologists, psychiatrists have done direct pay for years. It was kind of the original retainer medicine. But it works very well for even specialists. So primary care, family docs, works really well for us. Most primary care docs, I don't know how many you have. Yeah, I have 565, and I'm just about full. So 3,700 patients. And again, the hamster wheel of medicine is, as insurers reimburse less, I still have the same number of hours in a day. So I can either fit more in or go bankrupt or quit. So again, if let's say a mechanic can fix 5 cars an hour, but you make them do 10, some of those cars aren't going to work right, so they're going to have to come back. If he's fixing more than he can do, the appointment times for actually fixing your car are going to start to go out. I mean, you're going to run into problems. That's what we're doing in healthcare. It doesn't work. So we need to cut back on how many patients we are caring for, increase the time with them. All of our patients get at least a half an hour appointment. That's our shortest appointment time. And it's great if they come in and they just have a mole. Yep, that's a mole. Okay, thanks, doc. You have like 29 and a half minutes left. Anything else you want to talk about? But that's a luxury in a standard practice, because you just bought yourself that extra few minutes you're going to use with the next patient. So it definitely allows physicians to be better. The quality, again, we've been talking a lot about quality measures, but satisfaction definitely goes up. If you give physicians more time, quality will likely improve. It's basically it's like giving Marcus Welby an iPhone. You get 21st century care, but kind of with an old school touch of having time with your physician. Any questions?
Thank you so much, Doug. Great presentation. We love direct primary care. We love that model. You're not quite cynical enough, though, yet, as far as saying that we love insurance companies and we want them to make lots of money, because they don't want you to succeed. I'll just tell you that. But on the self-insured world, I mean, I think this makes a ton of sense, especially if the TPA is just getting a fee per employee per month fee like Healthcare Blue Book. We don't make any money off of the claims flow. A lot of claims, a little bit of claims, we get paid the same. So yeah, I like happy employers, and if we can cut their costs by improving their care, that's a wonderful thing. One of the problems, though, that we have seen when we've looked at the direct primary care model is, say, for an employer, let's say the employer is multi-location, even multi-state. The proposition would be that if we were going to do business with a direct primary care practice such as yours, well, that might be great for one location that's relatively geographically close to your practice. How do you all address that? Or are you all kind of coming in some sort of a hub and spoke model, or I hate to use the N word, network, but we're definitely not doing that. But I mean, how do you all address that?
Sure. So right now, our clinic is just in Wichita, and we've had that discussion. That's one of the things, looking at someone like Koch Industries, they have 70,000, I think, odd employees, but international even, that we can't do. So employers that are in one place, it works great. Actually, we've helped, at this point, I think we've gotten, we're somewhere in probably the 40 or 50 physician range of physicians around the country that we've helped transition from either a struggling practice to docs coming straight out of residency and doing this like us. Dr. Davenport, actually here in Edmond, is doing this now. So our goal really would be to set up something, whether it is a network, world domination is our goal, but lofty. But we would love to set up something to where if there are employers that have employees in different areas, to have enough of these clinics to where you could link them together. We actually developed our own EMR. Since I haven't coded anything for 4 years, using an EMR that makes me code seems silly. So we actually developed one that it does all the billing, and actually it integrates email and text. So when a patient emails me, it goes right in their chart. No EMRs do that because you can't bill for an email. But it also does their prescriptions. I just forgot to mention this, I haven't forgotten. But at the end of the month, you get an invoice. You don't get an explanation of benefits, anything like that. You get an invoice. And on there, it actually has what we've done, if you came in for visits, basically, but it's got your medicines, and it'll actually tell you how much you saved on your medicines compared to the average price at a retail pharmacy. So every month, people are just getting a little bit of a, kind of a reminder of why they're doing what they're doing. But that would be the goal. If we've got a company with multiple sites, to have physicians in those various, towns. And if you have a physician that's got enough, a company that has enough employees, if you've got some corner space somewhere, if you've got 1,500 square feet in the corner of your building, put a few exam rooms in there, and a doc can come in and day one be full and see, basically everyone. So that's a model that could work very, very easily for certain companies. But yeah, the goal is to transition more and more physicians to this, to where even if you're traveling, for us, for instance, if we have a patient and a family member, let's say grandma's visiting for Thanksgiving, develops a cough or falls and cuts herself, we'll see them for free. That's something that will extend to family members. So the goal might even be, if we get enough doctors linked together, that if you've got business personnel or employees that are traveling, they know that there's a doctor that they can stop in and see that's part of the group that they're with. So that'll be a goal.
If I understand correctly, you don't do Medicare either.
Nope.
So what is your experience with Medicare-eligible patients? Do you charge them a little extra? Do a lot of them still want to come see you?
Sure. So our pricing, like I said, it's we do $10 for kids, and then it's either $50, $75, or $100 just based on age. So Medicare age 65 plus is $100. The reason for that is we have an ultimate top number of patients that we'll see. By and large, the older patients that we have, there are more chronic conditions, more things that we want to pay attention to, more scheduling things like colonoscopies and health maintenance. So it kind of limits our overall capacity for patients as more older patients kind of dominate some of our day. So that's the reason for the higher price. But yeah, we do have several Medicare patients. They essentially sign a waiver saying that they understand we do not bill Medicare on their behalf. People can't try to submit bills to insurance for reimbursement because I don't document for insurance purposes. Very interestingly, and I figured this group, if anyone, would probably appreciate this, technically, per the law, because I do not submit claims electronically to CMS, HIPAA, federal HIPAA, does not apply to me. Now, that doesn't mean that we try to be completely outside and very unsecure, because there are still state laws, but technically federal HIPAA, if we're not billing, if we're not submitting claims electronically to CMS, all of HIPAA falls off. That is a necessity. So it's kind of fun.
Doug, if you don't mind, back to Jay's question, you might mention the website.
Oh, ours? Yeah, Atlas.md.
No, I'm sorry.
And then
I
One Medical.
want direct
Yeah,
care.
and I want direct care, yeah. So Josh and I usually, we have kind of a dog and pony show, and we haven't decided who's who, but so we usually, one of us will forget something and the other will remind him. We started a website called, it's iwantdirectcare.com. And we put that together for potential employees, or employers, I should say, for patients and for clinicians around the country to kind of put their pin in the map. Our goal really initially was to show that there is interest out there, that people want this, there's a movement. So, if you look, except for kind of, like Montana, pretty much the entire U.S. is just blanketed with pins. Clinicians, the same thing. There are more and more of them. And then employers that are looking to want to do this, or insurance agents, I should say, people that are in the insurance industry that want to work with employers and a direct primary care doctor to put those two pieces together, because, again, everybody wins. Patients save money, doctors make more money, or professionally satisfied. The employers save money and a lot of times can even hire more employees and grow because they're not burdened with the costs. And then insurers do better too. So it's a quadruple win.
And I certainly don't want to swipe your stage, but I will say to answer to the question that I've only been doing this for 6 months here in Edmond, Oklahoma. I've already had 2 other providers call me, one of whom called them first, and then they referred them to me. But there's already 2 other people in Oklahoma who have asked me, how are you doing it? I want to do it too. Will you help me? And taking the lead from these guys, I will help anybody who wants to do this from a provider perspective, because I personally believe that this is going to be the future of primary care, just to reinvigorate us, because the gentleman here who has 3,700 people to take care of, he's drowning. He's drowning. And until we figure out a way to get doctors back involved. And then besides that, I also have spoken with other providers just in my own town, one of whom told my wife, I want to do what he's doing. I'm just waiting to see if he can do it. So it will spread. It has been done. It will happen. My practice is thriving. They've been there for 4 years. There's other doctors around the country who've been doing something similar for even longer than that. But this is the wave of the future, and so.
Doug, real quick, as Jeff was just talking about, yeah, I do think that there's some growth. I mean, we're at just the tip of the iceberg as things get ready to really go. And I think a lot of self-insured employers out there, large and small, if they're self-insured, this takes a giant swath of their costs and turns them essentially into a fixed cost. That would be hugely appealing. I'll tell you, from my perspective as a TPA, it's also appealing because I don't have to pay all those primary care claims. I don't have to deal with the networks. I've got providers at primary care docs that are kind of thinking the same way. They're kind of in on the joke as far as cost, like Jeff was talking about. But another issue, have you all talked about as a group of direct primary care folks that there would be some sort of a physician-owned, say, collections or a billing and remittance type of mechanism? So, maybe, and I'm just thinking off the top of my head, but somebody like an Atlas MD, you all are your own practice, and then Jeff is his own practice, but for a health plan, maybe you all bill the membership fee to, say, the TPA on behalf of their employers, and then the employers, through their TPA, pay you, and then you send the membership fees out to all these. Because, if you've got an employer that's in 10 different locations or 100 different locations, and they're doing business with 50 or 150 direct primary care docs, and the employer is wanting to pay part of that, it becomes pretty burdensome, unless you just want the employee to pay for it and then the employer pays them somehow. But I would think that the employer's health plan would want to try to pay that membership fee if they legally could. But have you all thought about a mechanism to do that?
Yeah, we've worked a little bit. I'll put, we'll have to have one of our guys, kind of our thinker for payment stuff as far as insurers, Joe Martin. I'll have him talk with you a little bit more. So, yeah, we have thought about doing something to try to kind of bring it all together. Through our EMR, we can do quite a bit of billing. Since we built it, we can do stuff to, in there you could link up several different clinics and just have insurers built in. I think that'd be pretty easy to do. Because right now even, let's say for labs, our goal was to get all the physicians that are using the software, they just automatically get the pricing for Quest Diagnostics, Quest Labs. They just get the prices. They don't have to do the footwork to actually go out and find those prices. They just get it. So anything we can do on a kind of even a national scale to help, yeah.
Any direct specialty care groups in the Wichita area or in the Kansas area that have set up similar mechanisms as you have, and what their pricing schedule, or how do they?
As far as specialists?
Right.
The question is, are there any specialists that have kind of set up something like this? And we have worked with several. There's an endocrinologist in Boise, Idaho, that I just got off the phone with this last week. And I've worked with, there was a forensic psychiatrist also up in Minnesota that, just of the specialties. And basically the way that we have people come up with their fee schedule, because the thing you don't want to do is have, in primary care at least, is a fee for service, pay as you go, a la carte, and a membership, because essentially you're self-competing. People say, well, why would I be a member? And I hear it all the time. People say, well, I don't know if this is right for me. I never see the doctor. You call me a hell of a lot for not needing to see a doctor now that you're a member. So people that don't think they utilize care, it's mostly because they just don't have access. Once they do, they use it all the time, or more than they otherwise would. But it's fine. If somebody has poison ivy, they can email me a picture of it. They don't have to come into my office, because I don't have to physically see you to bill, because it's a membership. But somebody like a cardiologist would benefit from a hybrid fee for service. Let's say it's somebody that, I've got a 25-year-old with palpitations. I want them to go and see the cardiologist. They do an echo, say everything's fine. They're not going to be a member. They just needed to see him once. But if you're, let's say you've had a heart transplant, you're going to need to see someone, or you've had a cardiac ablation. A membership would probably work better, because you're going to see people more often, so that would make more sense. So yeah, there's definitely specialists, and you just kind of have to look at what volumes do you want, what's your clientele. Again, somebody in Beverly Hills is going to charge more than somebody in, Nebraska.
Do you have any issues with overutilization, perverse utilization, or have you worried about that?
Yeah, so probably the second most common question is, don't people abuse it? Second only to, well, this sounds too good to be true. We really haven't. We've never, in 4 years, we've never had to fire a patient for abuse of it. Narcotics, yes, but that's different. A lot of the times, Josh even, he had a patient that the guy was, he's in his early 40s, was so anxious and agoraphobic that, he essentially treated his anxiety with alcohol. He had an alcoholic peripheral neuropathy at 42. So, just very, very poorly treated, but he couldn't get out to see his doctor because that was his problem. He couldn't get out of the house. So Josh did a home visit every week for 18 months. But that's what he needed. And now he's essentially, he's doing so well. He comes to the office, gives Josh a big hug when he comes in. He's loving life again. But that's somebody that would call and make an appointment in a traditional office, would get anxious, wouldn't show, do that a couple times, get fired. Well, now you have somebody that still needs care, but they're not getting it. So there are some of those patients that they're not abusing it. You kind of have to redirect some people that, maybe they're perseverating or kind of OCD on some of their symptoms, but they still it needs to be addressed. But we've never had to tell somebody, just stop. You're overutilizing this. I even had Mike Pompeo, he's a congressman from Kansas, and we were talking to him, and he said, this would never work for someone like my mother. I said, why? Well, she'd be in there every day. I said, okay, pencil her in for 2 o'clock. Tell her to be there. What? I don't understand. I said, 2 o'clock every day. I'll see her. So I guarantee she's going to get tired of, it's not the mall. She's going to get tired of coming in. So he was like, oh, well, I guess that's true. It's like, yeah, it's a doctor's office. It's nice, and we try to make it pleasant, but it's still a doctor's office. It's not somewhere you go for fun. So it's not as much of a problem as people think. We are, basically, I've been on call 24/7 for 4 years, save for just a few vacations. But I can't remember the last time, within the last several years, that I've been woken up in the middle of the night with a phone call. Sometimes 7, 8 o'clock at night, I'll have a patient call, have a question about, a medicine at the pharmacy, and the pharmacist is gone, but there's this wall of cough and cold medicine for their children, what do I get? So you'll have some of that stuff, but I haven't ever had anybody abuse it, because I think they understand just how nice they have it, and they don't want to screw it up.
Doug?
Yes.
To follow up on the Medicare question, there's a lot of talk lately about alternatives to opting out, or exactly what our obligation is. As the 2-year opt-out with the private agreement with patients, as opposed to the voluntary unenroll. How did you guys handle that?
Well, you know, Josh and I, we look at this, we've talked to some of the healthcare attorneys. Technically never, you know, Josh never opted in for the clinic. He's never, you know, accepted with a tax ID or a Medicare ID number for the clinic. It's never been enrolled. But he's never technically opted out. And I still work in the ER, so I haven't either. But we've had people look at it to say, you know, when I'm functioning in the ER as an ER physician, and I see a Medicare patient, you know, I'm being basically, I'm paid to be there, an hourly rate, to take care of patients, but it's a service in that hospital in an ER setting, the hospital is billing, whereas in my clinic, if I'm seeing a Medicare patient, Medicare dollars are never spent. It's the patient's own dollars. So the attorneys and the accountants that we've talked to say, you know, it would be really difficult, if at all even possible, to say that I'm somehow abusing that, or I'm certainly not double billing. You know, they're two separate entities. But I haven't technically opted out only because I still work in the ER, and that's something that they, you know, want. But I've also heard from a lot of people that, you know, it's hard enough for people to find Medicare doctors. So if you opt out, the whole 2-year opt out is, you know, they'll kind of waive that. But that's just what some people have said. I don't know that for, you know, for fact.
Thank you, Doug, very much. Have you approached any other primary care groups in Wichita to help them adopt this process?
Yeah, physicians, we have somewhat, I guess. You know, a lot of the physicians are a very risk-adverse group. But I think some of them feel there's a, you know, for instance, the West Wichita family is a 25-physician practice. You know, they own ancillary services like MRI, CT, staff radiology. You know, they're spinning their wheels and playing the game as best they can. Unfortunately, we're a threat. You know, that's the way they see us. Again, you know, I mean, the 1,500 or 1,600 patients I have versus their 100,000, you know, Wichita can spare the few that are seeing me, but nonetheless, I can grow. I could set up a clinic next door and pull patients away very quickly. But there are a lot of physicians that are getting burnt out, certainly in Wichita, even some of the groups like MDVIP nationally. Yeah.
So
we haven't in particular, just because, like I said, some of them see it as a threat, but we've been approached.
So when are you going to start changing their paradigm?
Well, hopefully we're doing it on a national scale. You know, right now we've got the kind of the early adopters. You know, on the bell curve, we've got the people that, you know, they've put both feet in and they're going with it. There are the people that are waiting to see if it fails. Dr. Ray Seidel in Ruidoso, New Mexico. We converted him. He's a guy practiced for 25 years. He said, you know, for the last 10 or 15 years really hasn't been fun. I haven't enjoyed it. And he said, for the last 5, I've just almost outright hated it. And less than a month after converting to DPC practice, he called us and basically, I mean, almost kind of, you know, emotional, said thank you, that I wake up every day looking forward to going to work and taking care of patients, something he hadn't done in 15 years. So we've got those people, and he's told us about dozens of physicians around him, you know, because he's been in practice a long time, knows a lot of docs. And he said they're just basically waiting to see if it works or fails. So once they see that it works, that's when I think the tipping point, we're going to have a lot more do it. But, you know, Josh and I are, you know, we try to get the word out as much as we can. And you know, thanks to groups like this, the AAPS, dpcare.org, DPC United, there's a lot of them. We want to make sure they're not fragmented. You know, the worst thing we can do, the reason that we don't charge doctors to do consulting, even though it takes a lot of our time, is we want to see it succeed. Because as soon as that one practice fails, and then you get people pointing fingers and saying, see, we told you so, that free market medicine doesn't work, see? That's the last thing we want. So we want to make sure it's not fragmented and people, because we've seen a lot of direct care practices fail, and we can do an autopsy of their failure, and a lot of times it just comes down to value. You weren't a valuable entity for the patient. You cost too much, you didn't offer medicines or labs or what have you. So,
Doug, how many primary care doctors do you know who would trade their current position with you if they knew that the number of subscribers and the revenue was there so that they could eat and they could live?
right, so it's the chicken and the egg.
Right, and my point is really Jay's question, because we had this discussion a month ago here locally. It is the chicken and the egg. What happens first? Does the practice appear and then everybody cross their fingers and hope that the patients show up? Or do the individual patients and the self-funded employers drive this by maybe polling their employees and say, who are the primary care doctors that are seeing our employees and who are the ones you love? Let's go in and make them an offer that they basically can't refuse. Which happens first? And the reason I bring this up is it kind of gets to the whole purpose of why everybody's in this room, because it connects those who might be scratching their head that are risk averse. I agree with you. And fortunately, we're risk averse for our patients, but way too risk averse in all other ways. But it speaks to what this is really about. And I know primary care guys that in a heartbeat would trade with you. If the Koch brothers came in and said, hey, we're going to pick out the 30 top primary care guys in Wichita and just say, here it is, here's the subscription fee for all these people, and you walk away from your mess that you're in.
Well, if Charles and David want me to be their personal doc, I'd be the first one. But that's something that of everyone here, whether you're employers, employees, insurance, physicians, we all have one thing in common for sure. We're all patients. At some point or another, we utilize healthcare, so we all have that in common. We know, but when we opened our clinic, we knew that, it was a 10-year goal. Josh had been watching this forever, and he knew this is what he was going to do. He was going to open this clinic, and he moonlighted a lot to pay for it. But we were hoping that the patients would come in. Having them trickle in one family at a time or an individual at a time, it's great. But having employers, when we had Johnson's sign up, a 50-patient bolus all of a sudden, that really gets you started, because our overhead, we have 3 physicians that are basically full. We have 1 full-time nurse and 1 part-time nurse. That is our staff. That's it. We run our whole office with basically 5 people. So patients aren't paying for that now. So to get patients, you have to prove that it works. So nationally, as direct primary care, as people see that it's beneficial, the care's better, longer appointment times, physicians don't appear burnt out, they're not trying to rush you, they actually get to questions. As that increases, the number of people coming towards this will certainly increase. But being able to work with insurers and employers to get a doctor full, again, if I go to an employer that has, let's say they have 500 employees, and you take the 2.5 times that is kind of the market average for family. So now you've got 1,250. Well, that's two doctors worth of patients. Drop them in somewhere. If I told 2 doctors, you will be walk into your clinic day one, you'll see on average 5 or 6 people a day, and you'll make more than you're making now. You'll get to go home on time. Yeah, there are a lot of physicians we've talked to that would absolutely. Some worry, they say, well, I feel like I'd be abandoning my patients. Well, if you retire, you're going to abandon all of them. So, it's outright retirement doesn't fix the healthcare shortage. We've had talked to medical students and residents too. Direct primary care is a solution to the shortage because it gets doctors wanting to go into medicine. There was a study came out said about 22% of a physician's time is spent on non-clinical paperwork. Well, 22% times all of the physicians we have is like adding another 165,000 physicians to the workforce. So you can solve the doctor shortage just by giving us more of our time back. But if you can show that, doctors will switch, pretty instantly. And again, if you have an employer that has space, you can drop them right into the, the company, essentially. As long as people know, it's not the company doctor, so to speak. It's just, it happens to be the location, but a lot of people say, well, I don't want to see the company doctor because they're going to tell me I'm fine and go back to work. But so you want to make that distinction.
Yeah, Doug, I want to thank you and Josh because you've certainly been an inspiration to me, and again, I can attest because they've really helped me transition into a direct primary care practice. But I just wanted to throw a couple statistics at the non-physician folks around here that should be quite sobering. And if I'm wrong, please correct me, someone. But there are about 800,000 physicians in this country, and we're losing about 10,000 per year because of retirement or burnout, and they're going into administrative roles, not seeing patients anymore. So we really need physicians, and we especially need primary care physicians because if you get out of medical school and you have debt of $200,000, $250,000, depending on where you go, it's almost an intelligence test. Do you go into cardiology where you can make upwards of $500,000, $600,000 a year, or do you go into primary care where the glass ceiling is, for most of them, is $150,000 probably. So if you have that kind of debt and you choose primary care, people would say you need a CAT scan, you need your head examined. So the direct primary care model is really, I think, the way that we save primary care. And as you said, a lot of these docs are retiring early or getting burnt out going to administration, and maybe a direct primary care is not seeing 2,000 or 3,000, but as you said, seeing 600 is better than seeing none at all. So, and again, and the math is very simple. Let's just say 600 patients, and say on average $600 per year, a doctor's grossing $360,000, and basically the lower you keep your overhead, the more you make. This makes a primary care doctor make about as much as some of the lower end of the specialist care, which again is probably about the top 5% of primary care earners. So this is really the way to reinvigorate primary care.
Right, yeah, we've had physicians or students and residents usually, but students say that this has reignited a dismissed interest for primary care. They love family medicine. Of course, I'm biased, but you deliver a baby, do an ER admission, run a code in the ICU, and oh my God, what is your clinic all about? How many do you see a day? That everything else was fun, but that just sucks. I'll do something else. So we've had a lot of people say, yeah, no, that I could do. I enjoy clinical medicine, sitting down with patients, getting to know them. A classmate of mine, she went into ER. She said, I just don't understand you people, talking about primary care. I said, what do you mean? She's like, follow up. She's like, I just want to treat them and treat them. I don't really care about their history. I just want to just fix them and go. It's like, well, sorry you feel that way, but, for a lot of us, we actually like to know our patients. But for her it works. That's just, she's very good at what she does, but clearly doesn't have a primary care mentality. But yeah, this is something that definitely can get people back into primary care.
We have time for one more.
Care. I'm sorry?
Independent primary.
Right, yeah, and I don't, that's something that a lot of people don't think about, with something like an HMO, they're paying me a lump sum, the less I spend, the more I get to keep, but I'm just going to want to spend less on you in that case. What about pay for performance? The better controlled my diabetics are, the more I get paid, or the better I get paid. Well, what if I have a diabetic that likes cake? Clearly, I'm not going to have good control, so I have one option, I can fire them. Then they don't count against me anymore. But that's not really good, so having insurance dictate. We actually, at a coders meeting we were just at, we had somebody say, well, looking at insurance, and they say, the medical decision making, well who decides if, if an MRI is warranted? I friggin' do. That's why I went to med school. I talk with the patient, we decide that it's necessary. Again, it's their money, but I'm gonna tell them why it's beneficial, and we'll make a decision. But, having a bean counter make that decision for me certainly isn't a better option.
Just wanted to respond to independent primary care. I've also spoken with several specialists in the area, and I really honestly believe that they will follow suit once we get enough independent primary care physicians, because where do those specialists get their referrals? And right now, at least in this part of the country, everybody's employed, right? You're employed, sir. I was employed up until March 28th, and I'm not insulting any other physician who's employed, but as long as I'm employed by a certain health system, it's kind of expected that I feed the other specialists that are employed by said health system, and then that surgery occurs in said health system, and Oklahoma Surgical Hospital is worthless because that patient just won't even go there unless that patient has the guts to buck the system and tell their primary care doctor or their specialist, I'm not doing the surgery at said health system, I'm going to Oklahoma Surgical Hospital. But that's really hard for a patient to do. And patients will even sometimes ask the primary care doctor, well, who are you working for? Am I your priority or your employer? And so primary care has to lead the way.
Please join me in thanking Dr. Nonemaker.